chairpersons for the next session. I'll welcome Dr. Winston Nohroha, who is Senior Consultant and a General Surgeon at VS Hospital, Chennai. Welcome, sir.
Good evening.
I now invite Dr. Purli Ravi, Professor in the Department of Anesthesiology at Command Hospital Air Force at Bangalore. He is an ATLS instructor and a course director too. Welcome, sir.
Thank you, sir. Good evening.
Yeah. Now I invite Dr. Sanjeev Voi, sir. He's a professor and an emergency physician, and he's an emergency physician, say, a core member of our team at All India Institute of Medical Sciences. Welcome, sir, to this session.
Thank you, Dr. Abhinav.
Yeah, welcome, sir. And Dr. Amit Kalungata is a senior consultant at Healthway Hospital, Goa, and an ardent trauma surgeon, and his passion for trauma is immense. Welcome, sir, to the session, sir.
Thank you, Dr. Abhinav. Great to be here.
Yeah, it's a pleasure all you having here, sir. Now I hand over the session to Winston, sir. Kindly take forward the sessions.
Yeah. Good evening, everybody, and welcome to the session 5 on day 2, which is on surgeon, bleeding, and critical care. The first talk will be given by Dr. Mayur Narayan, and he will be talking on what a surgeon should know about surgical critical care. Now, just to give a brief introduction of Dr. Mayur Narayan, he is the Associate Professor at the Department of Surgery, also the Associate Program Director of Surgical Critical Care Fellowship, and the Director of the Skills Acquisition and Innovation Laboratory at the Weill Cornell Medical College, New York, USA. He has extensive experience in trauma and in intensive care, and I'm sure we'll all benefit by this talk. Dr. Mayur Narayan.
Good morning, everybody.
Yeah, for us it's evening, Mayur. Good evening.
Oh, that's right. For you guys, it is evening. You know, Russell and I have the time zone. So, can you all see my screen?
Yeah.
All right. Well, listen. Welcome to the talk, and I'm honored to be invited to the session. And the talk that I was asked to give is what surgeons should know about critical care. Well, it's a huge topic to cover in 20 minutes. And so I thought I'd give you a 30,000-foot view. I know that the intensive care is managed mostly by non-surgeons in India. Yet I would offer to you that just like emergency medicine, a few years ago was in its infancy and now has flourished under the leadership of Dr. Bohi and others around the country, that this could be yet another arena where surgeons could expand into and actually be leaders in this space. And so my heartfelt pranams and welcome to everybody who's attended, and let's get the session started. So, you know, Sushruta is considered the father of surgery. I think we have to give credit, and most people in the West don't acknowledge
Mayur, can you share your screen? I'm sorry. Your screen is still not.
It's not.
Yeah, we can only see you. We can't see your screen, Mayur.
Okay, no problem. Let me switch it.
Yes.
Yes, we are there.
Can you see the screen now?
Yes.
Yes, sir.
Okay. So again, you guys can see Sushruta on the screen. You know, he gets credited with being the father of plastic surgery. But most people don't know this, is that health was not only a state of physical well-being, but also mental, brought about and preserved by the maintenance of balanced humors, good nutrition, proper elimination of waste, and a pleasant, contented state of body and mind. And furthermore, he was instrumental in describing heart pain, circulation of vital body fluids like blood, rakta dhatu, or lymph, rasa dhatu, diabetes, madhumeha, obesity, hypertension, kidney stones. Maybe he was actually describing the field of critical care in its infancy. And in the United States, most people will recognize this person. This is Dr. Halstead, who's credited with the surgery or education of surgeons in our system. And if you look at one of his quotes, it says, every important hospital should have on its resident staff of surgeons at least one who is well and able to deal with any emergency that may arise. And I think if you think about the house of surgery and trauma in particular, maybe he was describing the surgeon who had equal skills in surgical critical care. And so for the US system, the American Board of Surgery helps shape the surgical critical care curriculum, and I'm going to get into that a little bit. We have a designated program director society, which is robust from each of the 160 or so programs around the country that regulate what needs to happen with those programs. And of course, the Society of Critical Care Medicine, which many of you are members, it's the overarching house which controls or gives guidance to the House of Surgery, anesthesia, internal medicine, in terms of all of critical care. And so if you look at these articles about what a surgeon should know, well, look at this. A surgeon in the ICU, an equal teammate or an intruder? We have surgeons who can't spell ICU, anonymous. A surgeon reported conflict with intensivists about postoperative goals of care. The relationship between the surgeon and the intensivist in the surgical intensive care unit. So you can see that there's a little bit of a tension between people who round in the ICU versus those who drop their patients off in the ICU. Each one of you who is on the screen on the Zoom call may have had a similar experience. You know your patient the best, yet you're dropping the care off to somebody else who may not have that same expertise, but may bring another set of cards, and there's a little bit of a tension. So we get into this model of open and closed models, and there's a third category, which is called the mixed model. And let me explain what this is. And so what I mean by open model and closed model and mixed model just means how you run your ICU. So the open model means that you have input into the ICU, there's less conflict, admitting physicians and surgeons may have better familiarity with their patients. The specialists continue care after ICU discharge. There's some cost-saving measures and there's minimization of handovers. In the closed model, and again, this is to be thought of where you have a little bit more stringent control. So it's true that closed ICU models are associated with decreased mortality and reduced ICU length. Sanjeev, you could please mute yourself. I think we're hearing an echo. You have better coordination of critical care services. There's a cohesive treatment strategy and a significant better use or more efficient use of resources. And so the specialty of critical care gets defined this way. This is the American Board of Surgery. And I'm going to go through this because I think it's important to lay out for the audience where India could be heading in this regard. So the specialty of surgery is really, in critical care, is a primary component of general surgery related to the care of patients with acute, life-threatening or potentially life-threatening surgical conditions, incorporating all of the knowledge and skills of non-operative techniques for supporting care of these ill patients, with a broad understanding of the relationship between critical surgical illness and surgical procedures. And if you look at the areas of expertise in terms of physiology, it ranges from tissue injury, trauma, burns, operative management, infections, acute inflammation, ischemia, and responses and interactions of other disease processes. So it's a pretty robust definition. You also have advanced knowledge and skills that allow you to provide comprehensive care of these critically ill patients from all surgical specialties. So if I have a vascular patient who has an aortic injury and you were in fact had to either employ a stent or they went for operative fixation, you know how to manage those patients. Similarly, if I have a vascular patient or I have a transplant patient, I have a plastic surgery patient, ENT, you can name the surgical subspecialty. They all get housed within the surgical ICU, provided by care by the surgical intensivist. So it requires a knowledge base and expertise that's quite broad. and making sure you can provide supports to each of the systems that you're caring for. I think more importantly, and to highlight an important role for intensivists, you will find that this role then provides leadership within healthcare organizations regarding the needs of critically ill surgical patients and the administration of critical care units. And I'm going to talk a little bit about how that was applied here and what surgeons did in particular with COVID in New York City. So, and the final bullet here is that they should be able to teach others and conduct research in the field. So the Leapfrog group is one group. It's a private group that collects, analyzes, and publishes data on safety and quality in order to push healthcare industry forward. And if you look at their recommendation over the past 20 years, they have encouraged hospitals to adopt a 24/7 intensivist model of critical care. This is an important concept because this allows hospital units then to provide the highest quality of care to critically ill patients, requiring that all intensivists, regardless of base specialty. And what do I mean by base specialty? So my base specialty is general surgery, there's anesthesia, you have internal medicine. Regardless of your base specialty, if you are a critical care trained, you need to have those credentials, you need to have training and be dedicated to the field. And there's, again, very strong evidence that says the presence of a specialized critical care team in an ICU setting reduces patient morbidity and mortality. And that's an important take-home message. I was honored to be a co-editor of the book that just came out recently. I encourage each of you to look at this. This is coming from the World Society of Emergency Surgery. This is intensive care for emergency surgeons, very applicable to the trauma surgeons in this arena and forum. What are the things that we actually need to go? So this book will get into the granularity of it, but I will give you some historical context and then give you a template for what I think every surgeon should know. So the care of critically ill surgical patients in specialized units really began in conjunction with our anesthesiology colleagues, right? It developed in parallel with how trauma care developed in our country. And wars, battle zones have been really the feeding ground for how these units came about. So shock units were established for the management of injured combatants. And if you look at the American College of Surgeons Committee on Trauma, they first published the resources for optimal care for the injured patient, our guide back in 1976. I'm dating myself now, that's the year that I was born, but a document that remains central in the verification of trauma systems and facilities around the country. On the picture to the left here, I don't know if anybody can recognize this, those of you that have visited the R. Adams Cowley Shock Trauma Center, this was the death lab. This was Dr. Cowley's first space. This is how the trauma center began. It was one room, and this is where they brought patients in. Again, Maryland being the first to employ the air ambulance system for civilians, but they used an Army helicopter to bring a patient from Western Maryland, and this is where they took care of the patient. And again, the guide that I was telling you, the resources for the optimal care, this shouldn't have to be invented in different institutions across the country, right? This is the guide that everybody goes to, and this is the guide that you are then measured against to make sure that your facility meets the accreditation it needs. Well, what about the factors that may influence the ability to provide intensive care modeling in surgical ICUs? This is important, right? Because you're going to need staffing. There's going to need to be an organizational structure within the hospital. What's your clinical productivity? Again, if you're in an environment where relative work units or value units, RVU generation, money generation is important, is there enough? What about academic productivity? What's the perception amongst colleagues who have traditionally held this position? No disrespect to our internists or our anesthesiologists, but when you enter the space as a profession, again, you're going to need to come with expertise so that they understand that, yes, you're an equal player within your own specialty of surgery, but also in critical care. So what are our options for staffing these as you grow this? Fellows in critical care can help. This is a training paradigm, just like you've done the trauma care specialty in India, and it is in its now several years in its iteration with the leadership of Dr. M.C. Mishra, Amit Gupta, Subodh Kumar, and others who have really developed the specialty for India. You can see here that there could be a need for fellows who are trained in surgical critical care at each of these units. Wherever a trauma surgeon would go, a fellow in critical care could go and then develop the specialty. The role of advanced practice providers come to place, and India has done this bottom bullet better than most. My dear friend Ramakrishnan down in Chennai in the Apollo system is a Pittsburgh-trained intensivist. He did it through medicine, but he has telemedicine systems where they're actually providing care because he's board certified in the US. They're housed in India. They're providing care to intensive care units in the United States because of the time difference. And so this is another benefit. The telemedicine is another way that critical care could be provided in the Indian subcontext. Advantages of having surgeons involved in the ICUs. So this gets to the crux of the talk. Surgical diseases are already known by critical care surgeons. The principles are common, the operations are understood, the nuances of which are easy to understand because you were there. This also goes with surgical infection. You understand the abscess, you understand the breakdown of the anastomosis better than anybody. And so it's only natural then that you would be the expertise in surgical infection. Surgical critical care programs can be developed for education. And finally, when you're talking to patients, you were there on the inside, you're managing. So I have the sickest patients that I take care of either in the trauma setting or emergency surgery, and then I admit them to the ICU where I continue to manage them. This comes from the book, the chapter we wrote on admission into the ICU, and why I put it here for understanding purposes is that the surgeon who is managing these patients, the trauma surgeon, the acute emergency surgeon, look at the full domain, the continuum of care that you are responsible for. You screen these patients, you operate on them, you provide curative management. If their disease progresses to a point where they're no longer survivable or if they have poor prognosis, you then engage with palliative care conversations with them, end of life discussions, and finally help the families through bereavement. So it's a full process. And this is an important concept that I think all surgeons, even if you're not an intensivist, should learn. This comes from Gretchen Schwartz, who's a vascular surgeon in Wisconsin, who really has come up with difficult decision-making for us. Each one of us is faced with, do I operate on this dying patient or not? And the family is screaming, please do everything, anything possible that you can do. Well, this is a tool that provides you in the ICU a checklist. It's called the best case, worst case scenario. You draw out what the best case is, you draw out what the worst case is, you give them some options. This is treatment option 1, this is treatment option 2. You use a narrative to tell a story when describing these cases. You include the patient's chronic medical conditions, and then you use questions that they've had to build into the discussion, and you finally make a recommendation. And what we found is when you describe this, people are less apt to say, please do everything, and they're much more rational in their decision-making. Surgical training in the United States has some prerequisites. You need to be a board-certified general surgery resident or eligible by certification by the board, and established ability as a teacher of medical students and residents. Now, if you look at the fellowship curriculum, this is what they're responsible for. Trauma surgery, 2 months, acute care surgery, multi-trauma critical care, neurotrauma critical care. This rotation was taken from the Shock Trauma Center where I did my training many decades ago, but I will tell you, this is one example. The requirement is that you need to do 48 weeks of uninterrupted time in an ICU. You also had advanced training. In the previous session, we heard about ATLS directorships, but you can see all the other offerings that critical care physicians are expected to undergo. If you look at the American Board of Surgery, what the requirements are, you need to do a 1-year training program to sit for the board. You have 48 weeks, you need to be certified, you need to have a full license to practice. These are the subject headings: advanced mechanical ventilation, airway management, shock, continuous renal therapy. We run our own. We don't need nephrology to tell us how to do dialysis on our patients. We do that. We give the nephrologist, when the patient's ready for intermittent dialysis, they then take over at that time. The management of dysrhythmias, neurologic disorders, including traumatic brain injury, hepatic failure, non-invasive cardiac output monitoring, full nutrition curriculum, all of the GI disorders you can imagine, surgical infection, miscellaneous procedures, injury, burn, endocrine disorders, organ failure, and end-of-life care. This is the full complement. You need to have a certain allocation, which is why the numbers are given on the side for you to be eligible to sit for the board examination. I was lucky enough to write the exam this past year. I wrote 10 questions out of the 100 or so that were written as a consultant to the American Board of Surgery. And this is what the exam covers: initial resuscitation, cardiovascular physiology, respiratory physiology. And I'm not going to read the entire page, but you get an idea of the breadth of knowledge that's required that adds to your fund of knowledge in addition to your own specialty to be able to take care of these patients. And then we ended up doing it just as well as anybody else, if not better. I think it's important, and we learned this during COVID, that if you look at the different specialties that have ICUs, and this is the US model, surgical ICU, medical ICU run by pulmonary critical care physicians, you have cardiac ICUs, which are run by anesthesiologists in the US model, some surgeons, and then finally the neurointensive care. I think it's important, and we learned this during COVID, that it's really one house of ICU. And an important concept that Tom Scalea once taught me, my physician-in-chief and one of my mentors at the R. Adams Cowley Trauma Center, is that critical care is a concept and it's not a location. The further you move away from fixed location to provide care, the better this is. And we learned this the hard way, taking care of many patients of COVID, as I'm sure you have. And why is this important? Well, the non-critical care folks were at home. Elective surgery was not being done, bariatric surgery, plastic surgery, endocrine surgery. All those folks who were otherwise just having surgery as their specialty were not busy during this time. It fell upon the trauma surgeons. So we gave trauma over to the general surgeons. We kept the critical care, so we did all of the intensive care management. I put these pictures up there to show you, this was the command center for where we would do our rounds. The board of the glass of the hospital bed became where we addressed the airway issues, what the ventilator strategies were, what drips the patients were on, what the gases were doing. And if you see the numbers on top of the board, 1, 2, or 3, this is designated our triage scheme, which we published in the Surgical Infection Journal about how to triage these patients. And in fact, all of our management of these patients was done outside the patient. I will wrap up here by telling you that we were able to establish, this is one of my victories coming to Cornell here, was to initiate a multidisciplinary critical care conference, keeping in mind the concept that we are critical care intensivists. And so I recruited neurocritical care expertise, pulmonary critical care, and anesthesia critical care, putting together a robust conference. And you can bring everybody together here. Anesthesia, MSK is Memorial Sloan Kettering. Many of you all know the cancer institution across the street, world famous. We invite their critical care fellows, pulmonary, neuro, and surgery, and frankly, anybody who's interested, and look at our topics for last year. Again, a broad depth of topics that fellows should understand. And since we're in the bleeding section, I think it's imperative that we talk about critical care techniques or resuscitation techniques such as ROTEM and TEG and how they're used in an ICU setting. Finally, I'll pivot and I'll tell you that in terms of what surgeons should know and how we can accomplish this. How do you make the bridge if you're still not convinced that surgeons should learn how to spell ICU and be actively involved in the management of these patients? We have a new field, which is acute care surgery. This is my chairman, Dr. Britt, who you see here on the far right. There's me, of course, Phil Berry, who's one of my partners and co-editors of the book, Acute Care Surgery. And many of you all will recognize Tom Scalea. I'm blessed to have these three people in my life as my mentors, friends, and colleagues who really have established the field of acute care surgery. And if you look at this slide, you look at trauma, which is blunt and penetrating, and critical care with the burn component. Then you take refractory intra-abdominal sepsis, perforated hollow viscous, necrotizing soft tissue infection, obstructions, all surgical interventions in the acute care setting. This is the first description of the emergency surgeon / intensivist. This was done by Dr. Britt many, many years ago. And really now the acute care surgery model takes shape. Back in 2003, you have the joint meeting of the trauma societies that say, look, we need to address problems of access to emergency surgical care. And frankly, with the development of and promulgation of non-operative management that each one of you is employing with all the guidelines, right? We're pushing the envelope for non-operative management. We're not as busy as we were back in the 80s, 70s, and 60s. And so with all due respect to the era of the giants like Ken Maddox, this is a different era. And so to keep ourselves busy, ICU care and emergency care lumped together really make a difference. And you can see the journey here from 2003 to 2018, how long it's taken, a decade and a half to really refine this. And this is what this looks like. You have trauma, emergency surgery, and critical care. You can do each of these. So you do elective surgery, I do emergency surgery, I do trauma surgery, and I also do ICU care, which gives me a robust week, and it makes for a very interesting week. So finally, this is the pillars of acute care surgery. The last pillar on the right you see here is called surgical rescue. Dr. Andy Peitzman from Pittsburgh, a giant and master in his own regard of acute care surgery and trauma, was one to include this, surgical rescue when somebody is crashing and burning and you need to go back after you've done repair. This is another pillar. And so the 5 pillars are trauma, emergency surgery, critical care, which is the central piece, elective surgery, and surgical rescue. So what about India? ICUs worldwide, this is Shirish Prayag. Back in 2002, look at the year. And if you look at his quote, it's more relevant now than I think it ever has been. Critical care in India is thus at a crossroads of development. The beginning has been made. There is still a long way to go. The field is full, a lot of dynamism, opportunity, and challenges. One hopes that all the efforts will lead to a humane, scientific, and meaningful service for the multitude of critically ill patients. And I think that's so true for surgical critical care. The battle in doctor shortage, it's really, difficult to manage. And this is 5 years ago, 2016, Indian hospitals after intensive care from afar. You can see critical care preparedness in India needs a booster shot. So the time is ripe, and I'm hoping that societies such as the Indian Society of Critical Care Medicine, ISTAC, and other trauma societies merge together so that when they do the redesign and the expertise of critical care units, that the surgery will be included in this household arena. The road to managing these critical care patients, as I open the door for my colleagues, Russell Gruen and others who will get into the granular aspects of bleeding, I was asked to give a 30,000-foot view. This is what it looks like currently, but I'm convinced with leadership, with the fortitude of people on this Zoom call and others around the country, that the road can look a lot more promising for surgical critical care. So I say pranams, thank you so much for your time, and I hope this was a appetizer to other discussions that really want to embrace surgical critical care in India. So thank you so much for the privilege, and I'm open to answer any questions.
Dr. Mayur, thank you very much for the wonderful lecture on the concept of critical care and also the scope and the training program, and also emphasizing the 5 pillars of acute care. I think the questions will be taken at the end of the 4 talks. Thank you.
Hello. Welcome, Professor Russell. I have the privilege to introduce Professor Russell to this extreme panel. He is currently the Dean, College of Health and Medicine at the Australian National University since 2018. Before it, he was the Foundation Professor in Surgery and a Director at Nanyang Technology University at Singapore. He is the visiting professor to Imperial College, a person who is well-traveled and is known very well among the Indian trauma critical care societies. He has been an expert in development of high-performing trauma centers, and he has co-authored a very lovely book, publication from Roadside to Recovery. I recently read it a couple of years back, a Monash University publication on the Victoria state of trauma health. And he has been the principal investigator for the PATCH trauma study, which changed the management of the early trauma, especially the pre-hospital trauma life support. He is the right man to talk to us about the early hemorrhage control in trauma. And Professor Russell, we look forward to your talk, and the stage is all yours. Thank you.
Thank you, Dr. Ravi, and greetings to all my friends. This is my favorite conference of the year, ISTAC, and if we can't do it in person, then we'll have to do it virtually, but it's so great to see you all. As many of you know, I've been studying various aspects of hemorrhage control for trauma for many years and running a large pre-hospital trial of tranexamic acid, and have been very much involved in systems of care. Now I'm coming to you from Canberra, the national capital of Australia, and here's our Parliament House, where we actually don't see an enormous amount of trauma. And in fact, we haven't even seen much COVID recently. We've had no cases in the last 5 months here in Australia's capital, Canberra. I have a very simple message, and that is stop bleeding, save a life. There's a lot going on in the trauma, as you know, at the scene, at the roadside, in the ER, in the ICU, in the OR. But every time we've looked at it, the things that have led to unexpected deaths or preventable deaths has been predominantly failure of hemorrhage control. It was what led to the establishment of the Victorian state trauma system. It was the key number one problem in our initial paper back in 2006 that I did with Ron Mayer and Jerry Jerkovich on errors in trauma care. Hemorrhage control is the key to preventing trauma death. And uncontrolled bleeding is the number one cause of preventable death. So stop the bleeding to save a life. We have done so much work on fluid resuscitation, saline, blood, platelets, cryo, other factors. We're studying tranexamic acid and other pharmacological agents. But the most important thing is none of those. It's stopping the bleeding. We've known since the 1600s with the experiments of William Harvey that circulating blood is critical to life. We've known since Vietnam that a bleeding patient pumped full of resuscitation fluid does poorly. We mustn't do that. We must stop the bleeding to save lives. We used to believe that the triad of death was hypothermia, acidosis, and coagulopathy. Then Karim Broey and his team defined and described an acute traumatic coagulopathy that occurred very early after major injury. That was back in 2004. Then we discovered the cellular elements of the blood and the circulation have a significant role in the outcomes after bleeding. And it all looked very complicated. This is an early diagram from Karim of trauma-induced coagulopathy or acute traumatic coagulopathy, showing the multiple contributors to that condition and to poor outcome. But in fact, as we learnt more and as we understood really what was going on, what's preventable and what's not, Karim simplified his diagram to just this. The problem is hemorrhage. Hemorrhage causes shock. The shock leads to an endogenous response, and then we fill the patients up with fluids. It doesn't matter whether it's blood, platelets, or crystalloid. We dilute the patient's circulation and we make it worse. The real solution is stopping the bleeding and saving the life. And why do I keep showing this picture of this woman with her thumb up? Well, this is Deb. She's one of my patients previously. She's given me permission to talk about her story and to show her picture. Deb had a very unusual road traffic injury. She was the driver of a car who swerved off the road and into a tree, and a branch of the tree penetrated her right axilla. And so she had actually just a complete brachial artery and axillary vein injury with some damage to her brachial plexus, but very little other soft tissue injury or bony injury. She bled profusely. When a farmer found her on the roadside, she had a barely detectable and very rapid pulse and was unconscious. quick thinking, the farmer put pressure into the wound after removing the tree, or her from the tree, called the ambulance. The ambulance put pressure on the wound as they flew her to the hospital in the helicopter. And when I received her, I took over from the ambulance officer and put pressure in the wound. And we took her straight to the angio suite, where we had a balloon put in place first, and then we took her around to the OR, and she survived. This was the site of her injury. And now we know much more about what happens in the microcirculation from experiments like this with animals, including large animals, of course, as well as small animals. And this is a cartoon of what's happening in the microcirculation as a patient bleeds out. This is happy, healthy, normal microcirculation. You can see the circulating cellular elements and platelets and clotting factors represented in blue. A nice quiescent endothelial layer of flat, non-activated cells and tight junctions in between, and the yellow cells representing the interstitium, with everything being happy as Larry. What happens in acute hemorrhage? The early response is arteriolar vasoconstriction to maintain circulation to vital organs. But of course, that does terrible things to the peripheral circulation beyond the arterioles. And we get capillary microcirculatory failure. What you can see here is several things happening. Of course, blood flow is very much reduced. There is extensive hypoxia of the distal capillary circulation. The endothelial lining cells in purple become swollen, activated, expressing cellular adhesion molecules. The tight junctions between the cells break and open up and become permeable. The activation molecules lead to marginalization and transgression of neutrophils. Those activated neutrophils then release their toxic substances into the interstitium and cause extensive interstitial inflammation. What you see at the bottom branch of the capillary is complete occlusion and failure of that capillary due to cellular debris, activated clotting factors, and cellular material that has become non-conformative and unable to transgress the capillary. All of this is caused by bleeding. If you pump then full of crystalloid, you make things worse. It tends to lead to increased activation of neutrophils and a really toxic situation, both in the microcirculation and in the interstitium. And even so-called hemostatic resuscitation, using a nice balance of blood products, still leads to a highly activated situation. So the solution is, as we know, stopping the bleeding, as well as preventing and treating coagulopathy, maintaining critical perfusion, and limiting harmful inflammation. But the number one thing, as Deb showed us, and the reason she survived, was a smart farmer, a persistent paramedic flying in a helicopter, and a compliant junior consultant surgeon at the time, who simply put a lot of pressure into this woman's axilla and stopped her bleeding out. So stop bleeding. Put pressure on the wound, pack wounds, use tourniquets, use smart dressings that promote coagulation if you have them. Use clever things like angiographic balloon occlusion and angioembolization. This is actually Deb's angio films. You can see the exsanguination of a transected axillary artery on the right. You can see an inflated balloon on the lower left, and no resulting hemorrhage in the upper film there. If you may need to operate, do it, and do it quickly. Some of you may be blessed with advanced theatres and hybrid theatres. Fantastic, but don't let any of this stop you actively addressing the hemorrhage as early as you can. So with Deb in mind, I leave you with a very simple talk and a very simple message, which is where I've landed after all of the work that I've done and all of the interesting stuff that I still am studying and doing, all the wonderful people that I've trained from and met, and all the incredible biology of critical care and trauma that I deeply love and find so fascinating. But ultimately, this is all about early hemorrhage control. And so I leave you with the question, how long does it take your patients to stop bleeding? Thanks, Dr. Ravi. I'll stop sharing my screen with this, and I look forward to the other presentations and to answering questions.
Thank you, Prof. Russell. That was an excellent presentation and the importance of stop the bleed as soon as possible. And I hope you are watching India's Australia matches out there.
I know. Sri Lanka is playing tonight here in Canberra.
Oh, that's
I'm with
great.
you guys instead.
Thank you. Thank you very much. Thank you very much and we will take the questions at the end of the session, Professor Russell.
Thank you, Dr. Russell, Dr. Bhoi here, and it gives me immense pleasure to invite the next speaker, Dr. Ajay Malhotra. He's the Division Chief of Acute Care Surgery at University of Vermont Medical Center, and also the Professor of Surgery of University of Vermont College of Medicine here. So he is going to speak on trauma-induced coagulopathy. So may I ask Dr. Ajay to take over from.
Good afternoon. Can everybody see my screen?
Yes, Dr. Ajay.
Yes.
Namaskar, and thank you, Dr. Bhoi, for the kind introduction. It is very difficult to match two excellent talks, and it's interesting. We went from a 30,000 view of critical care down to a very simple but important message of stopping the bleeding, and I'm left with this very, very complicated topic of trauma-induced coagulopathy, but I'll see if, what we can do. So I always feel that to understand where we are and where we need to go, we should know where we came from. So what about the past? When I was a medical student a long time ago, we were always taught that coagulopathy after trauma is a secondary event, which happens late. The cause is consumption and dilution of factors, and the amplifiers are acidosis and hypothermia caused by the shock. And this was primarily based on the tests we had. They were fairly crude: prothrombin time, activated plasma APTT, and overly simple understanding of the intrinsic and extrinsic pathway, which was much more overly simplified than what the actual truth is. And this led to the recommendation that aggressive crystalloid resuscitation, as was pointed out by Russell, some RBCs thrown in for oxygen carrying capacity. And I remember clearly that we were always taught you do not give plasma or platelets till the laboratory parameters become abnormal. And this is very similar to what Russell had shown. Basically, trauma leads to hemorrhage, hemorrhage leads to shock. We resuscitate the patient, and the downstream effects of that lead to the coagulopathy. So this was our prior understanding. So what changed? Well, we went to war, and what people observed was that there were better outcomes with less crystalloids and early use of whole blood. So we were told to learn from the mosquitoes, give blood. All these mosquitoes can't be wrong. Then we developed these finer tools, point of care thromboelastography, which can really break down the various elements of the coagulation cascade to truly understand what's going on. And we got a better understanding that this coagulation cascade is much more complex than what we were thinking, and it is intertwined with inflammation and fibrinolysis cascades. So this was our original understanding, this intrinsic pathway and the extrinsic pathway. That turned to this with important intertwined relationships with the inflammation and fibrinolytic pathway. And at this time, we are here. There is still that intrinsic and extrinsic pathway in there somewhere, but it is much more complex and much more interrelated than we previously thought. So trauma-induced coagulopathy, well, only nature can provide the beautiful balance as seen by this picture. I love this picture. And looking at the coagulation part of it, basically there is this balance between coagulation on one hand and anticoagulation. So coagulation makes the clot, anticoagulation prevents the clot from being formed, and also fibrinolysis. Once a clot is formed, the destruction of the clot. And this is very finely balanced in our body. Right now, all of us sitting have some amount of coagulation going on in our body, which is finely balanced with the anticoagulation forces and also fibrinolysis, so our blood circulation does not stop. So trauma-induced coagulopathy has been defined as a clinical syndrome due to an imbalance between the coagulation, anticoagulation, and fibrinolysis that is caused by tissue injury and shock in the early stages of trauma and has a major impact on patient outcome. So I have italicized some elements to it, that it's an imbalance of this very fine balance that nature has given us. Second, it is caused by tissue injury and shock, and it starts within minutes. Just like when a patient gets injured, inflammation starts within minutes. Similarly, the trauma-induced coagulopathy starts within minutes. It is not a secondary phenomena. Actually, it is part and parcel of the trauma, and it has a tremendous impact on patient outcomes. So this diagram actually can be expanded to this part, that there is an early element to it, which is the trauma-induced coagulopathy, and that is worsened by the systemic acquired coagulopathy with the shock and dilution and everything going on. So the focus of this talk is primarily the trauma-induced coagulopathy that occurs early, and it is part and parcel of the trauma, and it is not a secondary event. What are the characteristics? I mentioned it is rapid in onset. It occurs within minutes after the trauma occurs. This correlates with the magnitude of trauma. So there are beautiful studies which show that it is correlated with the ISS, Injury Severity Score, and also the duration and depth of hypoperfusion or shock, as was in Deb's case that Russell demonstrated. And all aspects of hemostasis are affected. Primary hemostasis, so platelet function, affects the platelet aggregation, and secondary hemostasis, which can be studied through the thromboelastography, the initiation, which is defined by the R time, the rapidity of clot formation, which is defined by the K time and the alpha angle, the maximum clot strength, and then fibrinolysis. Each of these elements are affected, and it's only by using these very fine tools have we been able to better understand and define trauma-induced coagulopathy. So what is the pathophysiology? Well, once tissue trauma occurs, what should happen? There should be generation of prothrombin activator, which is factor 10A, that, as we were taught, it can happen through the extrinsic or intrinsic pathway. That leads to the cleavage of prothrombin into thrombin, which then cleaves fibrinogen into fibrin monomers. Fibrin monomers then form fibrin polymers that interact with platelets and form a stable clot. So this is what should happen, the way nature designed everything. But if the trauma is a little more, then in addition to this normal pathway, endothelial damage, again, some of Russell's cartoons are there, and protein C activation are the two principal elements or principal pathways it is felt that trauma-induced coagulopathy takes place. Endothelial damage leads to glycocalyx disruption, and that leads to some autoheparinization because glycocalyx is rich in heparin. And also I have to say, this is the first time I read about this Weibel palade bodies degranulation from the endothelium, which release TPA and increase fibrinolysis, and protein C activation, which leads to factor V and factor VIII inhibition. So it reduces the formation of thrombin, and then plasminogen activator inhibitor 1, which directly leads to fibrinolysis. So this is the current understanding of the cellular mechanism that trauma-induced coagulopathy is caused by. And as I said, it starts as soon as the trauma happens. This is a chart showing that more injured the patient, the incidence of coagulopathy keeps on rising. On the x-axis are the ISS scores, and on the y-axis are the patients with coagulopathy. And it has a tremendous impact on outcome. So for each of the ISS score, patients with coagulopathy, shown in the dark black bars, had a higher mortality. So it affects outcomes. This is another one which shows the same thing, that patients can present in any form. They can be even hypercoagulable, hypocoagulable, or a mixed picture. If you are hypercoagulable, then also your mortality is twice if you did not have coagulopathy. And if you're a mixed or hypocoagulable, then obviously your mortality is 4 times higher. So what does this all mean clinically? Well, there can be any combination of quick or delayed onset of clotting as measured by the R time, rapid or slow clotting as measured by the K time and alpha angle. You can have a strong clot, or you can have a weak clot or non-existent clot. And then there can be hyperfibrinolysis or complete fibrinolysis shutdown as measured by the LY30. So it leads to a dynamic interplay between the spectrum of coagulation, strong clot to weak or non-existent clot, and a spectrum of fibrinolysis, major fibrinolysis to fibrinolysis, complete fibrinolysis shutdown. How can you prevent it? Again, don't get injured. That's probably the best advice you can get. One of my orthopedic surgeons used to say, don't fall. But if you fall, don't fall on your outstretched hands, because every fracture in the upper extremity happens by falling on an outstretched hand. So don't get injured. But again, just very well shown with Deb's case, pre-hospital, rapid transport to a trauma center, analgesia, sedation curbs the inflammatory response, keep fractures immobilized, prevent more tissue injury, permissive hypotension, maintain perfusion, minimize bleeding, stop the bleed, and minimal resuscitation to maintain a pulse. You do not give a lot of anything that you have, just a little bit to maintain the perfusion till you stop the bleeding. In the hospital, rapid assessment to detect hypoperfusion shock, resuscitation, again, minimize crystalloids, and early switch to blood products. And rapid control of hemorrhage. Probably the most important concept is to get it quicker and quicker, because as soon as you stop the bleeding is when the patient will start to recover. What about treatment? What about patients who have already come in TIC, where the trauma-induced coagulopathy has already set in? Blood product resuscitation, again, 1:1:1 ratio, or it can be TEG-based if TEG is available. And a lot of places don't have TEG, so I don't think anybody should feel bad if they don't have TEG. 1:1:1 is working pretty fine. Damage control, permissive hypotension, minimal surgery to control hemorrhage and contamination, and do not do any more. Come back. For he who runs away will live to fight another day, but he who is in battle slain will never rise to fight again. So do the minimum, run away, and come back. This is from the war, showing the ratios. Better the ratio towards the right, better, lower the mortality. So high plasma to RBC ratio was independently associated with survival, with odds ratio of 8.6. And then these studies were repeated in the civilian world. These were massively transfused patients. And again, high plasma and high platelet to RBC ratios showed the best survival. So 1:1:1 ratio, current status, results confirmed by multiple studies. Experimental evidence supports that early administration of PRBCs, plasma, and platelets in 1:1:1 ratio ameliorates TIC. Now, what about early resuscitation? So I give you a case which was part of a trial. This was a 37-year male. He was involved with a motorcycle crash. Blood pressure at the scene was 70/50. This is his point of care TEG at the scene. As you can see, there is delayed onset of clot, poor perfusion of clot, weak clot with a low maximum amplitude, and too much fibrinolysis going on, clot destruction. So this was part of the COMBAT trial in which they were testing out pre-hospital use of plasma. So they actually gave 2 units of plasma in the field. By the time he made it to the ED, his pressure had improved. He was still tachycardic. His fast was positive. And this was his TEG. So again, the initiation of clot is earlier, probably a little faster clot formation. Maximum amplitude is better. That means stronger clot. Still significant fibrinolysis going on. And if you look at the time, this was 1843, that is 6:45, and then he was in the ED. The next one was just after 7 o'clock. He was rapidly taken to the OR where a spleen was removed. He received 3 additional units of PRBC and 1 additional unit of plasma and very minimal crystalloids. And by the time he made it to the ICU post-operatively, he was hemodynamically normal. And look at his TEG. This is just after 8 o'clock. And TEG is near normal. Actually slightly hypercoagulable because it seems that he's initiating the clot very early. But this is a pretty normal TEG, and the fibrinolysis has completely disappeared down to 2.3%. The total blood products that he received were 3 units PRBC and 3 of plasma. Now, I did want to spend a couple of minutes talking about the CRASH trial because fibrinolysis and TXA is getting a lot of press, of course, for good reason, and Russell has done a lot of work on this. So it was an international double-blind randomized multi-center trial on traumatized patients of TXA versus placebo. Clinical inclusion criteria, and I think these are important, in the judgment of the treating physician. So there was no need to be evidence of it, but if the judgment of the treating physician, the traumatized patient is bleeding or is at the risk of bleeding, pretty much any trauma patient can fall into this category. And the primary hospital outcome was 28-day mortality. Secondary outcomes are vascular occlusive events. And it was an amazing trial, 20,000 patients randomized with very few dropouts, resulting in over 20,000 patients analyzed. The groups were well matched, and the mortality was better for the TXA. It was statistically significant, and the odds ratio with the confidence intervals are there. The difference in mortality from hemorrhage was actually, the difference was even smaller, but still statistically significant. But look at that, that absolute difference was 0.8%. From 5.7, it dropped to 4.9. Thrombotic complications were not elevated in the TXA group. No difference in, now this is also interesting, that if the TXA is truly stopping the bleeding, then the need for procedural hemorrhage control should be less, but there was no difference in that. There were no difference in blood transfusions. Again, leads to some question that is the TXA doing what we think it is doing? So if you analyze the result, the strengths, greater than 20,000 people randomized double-blind fashion. Wow. It is truly an incredible effort that these folks pulled off. And it was done in 40 countries across 6 continents. But what are the weaknesses? 40 countries across 6 continents. Countries varied in maturity of system and blood banking. Greater than 80% of the patients came from underdeveloped countries. So in a more mature system, will these results be still there is a little unclear, and more studies are going on. And inclusion criteria, as I mentioned, were quite subjective. And of course, I understand why no laboratory parameters were there, but if you look at it critically, then you are stuck with no laboratory parameters. And there was some hint or signal that patients receiving TXA more than 3 hours had a possibility of harm, though it was not statistically significant. So what about fibrinolysis? This is a more nuanced understanding of the process. We looked at, this was the Denver group, looked at 180 severely injured patients in shock. Their median ISS was 29, it's been pretty high. The IQR was 22 to 36. Base excess was -9, so again, in shock. And this is what they found with the TEG results, that these patients fell into 3 categories. These are the numbers. Out of the 180, about 115 showed impaired fibrinolysis, 32 showed normal fibrinolysis, and 33 showed abnormal fibrinolysis, hyperfibrinolysis. The mortality, as you can see, was the lowest in the folks which had physiologic fibrinolysis. But what is important is it possible, so that's the mortality, is it possible that the TXA benefits these folks? Because that is hyperfibrinolysis, it's an antifibrinolytic agent. But what about these folks? Could TXA be harming these folks? So it is a relatively non-specific drug, and it needs a little more nuance, in my mind at least, for mature systems. And you can say that was just over mathematization of the stuff. But here's the most interesting part. The people who were in hyperfibrinolysis, their cause of death, as you can see, the big red bar, was primarily hemorrhage, as you would expect. When there's a lot of fibrinolysis going on, you bleed to death. And the people who were in shutdown, there the fibrinolysis was less. Their cause of death, shown in the green bar, was more often from organ failure. Again, it makes sense that if you have fibrinolysis shut down, your capillaries can get clogged and you may have organ system failure. This was repeated in a multi-institution and the same multi-institutional trial, and now more patients, and exactly the same results between shutdown, physiologic, and hyperfibrinolysis, and exactly the same results between the cause of death. And here's where they have the survival curves, and the pink one at the top is the physiologic. The green one in the middle is fibrinolysis shutdown, and the lowest bar, the highest mortality, was in patients with hyperfibrinolysis. So what does it mean? The patients injured will come to you. Some of them will be in their physiologic state of fibrinolysis. Approximately 15% of the highly injured patients, they have a low mortality, and there is a potential for harm for TXA. Shutdown, about 50% of the patients are actually in shutdown, and that also has a high mortality, and TXA may be harmful. The highest mortality is seen in the hyperfibrinolytic group, 35%, and the TXA may be of benefit. And this distribution of patients may explain why we see the benefits of TXA in the CRASH-2 trial, because the highest mortality is in the folks which are in hyperfibrinolysis. But there is a potential for harm. And multiple papers coming out, TXA associated with increased mortality in patients with physiologic fibrinolysis, increased risk of fibrinolysis shutdown among severely injured trauma patients receiving TXA, and it just goes on. I'll give you another example of a case. This is a patient, my patient. About 11:15 in the afternoon, in the morning, there was a ski crash, and the resort called for air evacuation. This is a 24-year female. She was boarded up, put in a C-collar, and in the pre-hospital, as you can see, she was doing reasonably well, except for her systolic blood pressure, which was in the 60s and 70s. TXA was given en route. Actually, it was surprised that they were landing on our roof and they were giving TXA. So red alert. This is a basic primary. FAST was negative. And she had this pelvic fracture. She was pan scanned, and you can see she had a occipital condyle fracture. and the bad pelvic fracture with active hemorrhage. So plan was angioembolization. While we were waiting for IR team to get in, 15 minutes, this was a very dramatic event. She was a young person. I was there. The whole team was there. And from talking, she just went to GCS of 6. The rest of this was same. So we secured her airway, repeated a head CT, which was negative. And we also did a CT angiography of the neck. And you can see the basilar artery has thrombosed. And that's what led to her acute deterioration in a neurological status. So we changed the plan that we will control the bleeding, angioembolization, but then we got our neuro IR people to remove the clot from her basilar artery. Pretty amazing what these guys can do. Hospital course and the TEG we had obtained showed complete fibrinolysis shutdown. Now, of course, just one patient, but this is a young person, 37 years of age, having basilar artery thrombosis. It sounds very weird. Fortunately, because of the quick IR, the stroke became mild. Impact was likely reduced by the immediate intervention. Her pelvis was fixed, and hospital day 13, she was discharged to a rehabilitation center. So status of TXA, at least in my mind, as Halstead said, before drinking from the cup of new knowledge, the surgeon is well advised to let the froth settle down. I don't think the froth has settled yet. Multiple studies are ongoing, so stay tuned. So my recommendation for TXA, severely injured bleeding patient, initiate MTP 1:1:1, perform TEG. If there is hyperfibrinolysis, certainly give TXA. But if there is shutdown or physiologic, do not give TXA. Thank you.
Thank you, Dr. Ajay, for that excellent talk. And it was really very enlightening. Actually, I engrossed in your talk, so before I could respond. So we'll take the questions at the end of the whole session. So I'll hand over to the next person.
Hello, everyone. Thank you, Dr. Sanjeev and Dr. Ajay, for the excellent talk, and Dr. Sanjeev as the chairperson of the last session. Hello?
Amit?
Yeah.
Yeah.
Am I audible? Hello?
Yes, am I audible?
Yeah, Amit.
Yeah, okay. So thank you very much, Dr. Ajay, for the lovely talk, and Dr. Sanjeev for having...
Amit, can just...
Yeah.
Yeah, Amit, I'm sorry to interrupt the session. I am Dr. Amit Gupta this side. First of all, thanks to all the wonderful speakers who've joined us, the old friends. Just a business announcement I have to make for the ISTAC members who are in the hall, Hall A. Actually, ISTAC general body meeting had to be at 6 p.m. and therefore many of them have joined this particular session, which had to be off the hall. Just an announcement for them that I hereby convene the general body of the Indian Society for Trauma and Acute Care for the year 2020. And since the session is going on, I would adjourn it for another half an hour. And after that, you can all join in by the same link we had sent you on the mail. So you have a mail, link, and then you can join. Then we'll have a short general body meeting of the Indian Society for Trauma and Acute Care. Sorry once again. And yes, only members are allowed to join. So kindly, if you are not member, then kindly excuse us. I'm really sorry to interrupt the session, but it was an important message for the members. Right. Thank you.
Thank you, Dr. Amit. Hope that message was loud and clear for all the ISTAC members. Coming back to our session, which is in full flow and really interesting, we would like to welcome Dr. Joseph Matthew. Dr. Joseph?
Yeah, I can hear you. Thank you.
Yeah. So Dr. Joseph Matthew is an esteemed member of the Trauma Society. He is the Deputy Director of Trauma Services at Alfred Health. He is the head of the International Program South Asia for National Trauma Research Institute. He is the Associate Professor at the Central Clinical School of Monash University and is associated with the Center for Software Innovation at the Deakin University. We are going to now hand over the session to him. He's going to discuss the endpoints of resuscitation in hemorrhagic shock. Dr. Joseph, over to you.
Thanks a lot. I hope you can see my screen.
Yeah.
Thank
you. Joseph, not as yet.
Sorry, can you see the screen?
No, we can't, Joseph.
Sorry.
No, I think you'll have to share it again.
Okay.
Yes, now it's fine.
Yeah, thank you. Thanks everyone, and namaskar, and a special thank you to Amit, Subodh, Professor Mishra, and ISTAC for inviting me. It's wonderful to be among friends, and it's a privilege always to talk in this conference. So I'm going to be talking about the endpoints for resuscitation in hemorrhagic shock. It is a pretty dry topic, but at the same time, it sort of is in the trauma care continuum of early onset coagulopathy, trauma-induced coagulopathy, and then ongoing endpoints for resuscitation and where you actually stop when it comes to hemorrhagic shock. So the Alfred Trauma Services in Melbourne, we see roughly around 9,000 trauma admissions per year and roughly 1,600 major trauma patients. And worldwide, hemorrhage is the leading cause of death. This roughly equates to around 16,500 people every day who dies from injuries, and out of which around 6,000 die related to bleeding, which is responsible for around 35% of the pre-hospital trauma deaths and over 40% of trauma deaths within the first 24 hours. So I'll start off on that statistics. Within the Alfred, the number of hemorrhagic shock patients that come in, roughly around 80 to 85% is related to, in the number of shocked patients that present to the Alfred, roughly around 80 to 85% is related to hemorrhagic shock. So this is a classic case that we saw a few months back. It was a 45-year-old lady who actually absconded from an inpatient mental health facility and jumped from a bridge, which is approximately around 10 meters. And the injuries, according to the paramedics, was a massive hemothorax and a possible pelvic injury. Her GCS was 14, so she was mentating, but you can see she was profoundly hypotensive and significantly tachycardic, and her oxygen saturation was 94%. We had around 10 minutes notification, and she was around 30 minutes away still. So we were initially told she was intubated. Thankfully, they didn't intubate with that blood pressure. They put, our paramedics put 2 pneumocats and thoracostomies, digital thoracostomies on the way, pre-hospital, and then gave 4 units. Our paramedics carry pre-hospital blood, so gave 4 units of blood and 5 liters of crystalloid just to keep her going and perfuse to the hospital. On arrival, she was still GCS 14, mentating, now her blood pressure was unrecordable, which is obviously a low volume state, and was significantly tachycardic, and her SOX had dropped down to 93%. Her fast was positive for blood, but saying that it was not the most impressive amount of blood inside the abdomen, but we literally could see massive amounts of retroperitoneal blood. As you say, fast is not really good for picking up retroperitoneal blood, but in her case, we could see in the retroperitoneum there was significant amount of bleeding. So the injuries identified, in the trauma screening, we found that she's got a complex pelvic fracture. She's got possibly you can see some veiling on the right side, possibly some hemothorax on the right side. It's a supine X-ray. And she had an open wound in a leg and a femur fracture. So it was an open femur fracture through which she was bleeding significantly. So the possible injuries at the end of the bed with that sort of imaging, we knew she had possibly a mild head injury with the low GCS. Possibly it could be related to hyperperfusion of the brain. But we did suspect complex pelvic fracture with a massive retroperitoneal hemorrhage. The intraperitoneal, we also suspected intraperitoneal bleeding. It was actually a grade 4 liver laceration on the CT scan. She had a left femur fracture with massive hemorrhage and other lower limb fractures. And she did have multiple spinal fractures also. So the endpoint markers at that time in the resuscitation bay was we had a mean arterial pressure, which is pretty low. 40 was the systolic. The mean arterial pressure was obviously lower than that. And she had received already 4 units of Paxils and 4 units of FFP. And obviously she was bleeding significantly into her retroperitoneum. As you know, it's a roughly around 6 to 7 liter space, and it's a huge space to bleed into. She was continuing to be tachycardic, which is another endpoint marker for resuscitation, in spite of resuscitation starting. Oxygen saturations of 94%. Her lactate was 9.6. Her base excess was -8. Her INR was 3.1. Fibrinogen was 0.8. And the bedside fast or ultrasound, and most of us do use this for guiding our resuscitation, showed a collapsed IVC, completely collapsed IVC, and a collapsed right ventricle. So we knew she was exsanguinating still, and whatever we were throwing in, she was just bleeding out. So as Russell mentioned, the main aim was to try and achieve bleeding control. So that is what we wanted to do. So on that, I start off with the learning objectives of the definition of shock, to describe what are the endpoints or the end markers of resuscitation. And I would go on to compensated and uncompensated shock, just touch on it because most of you know about it. Importance of resuscitation endpoints, damage control resuscitation, which I would describe as the 4th point of endpoint of resuscitation, and then future managements. So as you know, shock is the imbalance between the delivery of oxygen and the consumption of oxygen. And as ATLS manual, which everybody has read, describes, it's an abnormality of the circulatory system that results in inadequate organ perfusion and tissue oxygenation. On the right, you can see the graph, which shows the glycolysis pathway. Usually there's around 36 ATPs being formed, and there's pyruvate that is being formed, which is around 2 sets of molecules of pyruvate. In hyperperfusion, the anaerobic metabolism takes place, and it's exactly reversed. You have got less ATPs and you've got more pyruvate, and obviously that means you end up with more lactate. So in a compensated versus uncompensated shock, it is important to utilize this to understand the endpoints, but also we are typically confronted with hypovolemic or hemorrhagic shock in the trauma setting. And the ATLS manual classically classifies shock based on straightforward physiological parameters, which includes heart rate, blood pressure, mental status, and urine output. But as a clinician, you know, none of this is going to give us a complete picture of the level and the state of shock or the physiological abnormalities that are happening in the cellular level in this particular patient. So the utility in the initial assessment of shock to guide your treatment is good, but none of these parameters on its own or none of these parameters together is going to give a complete impression of what is happening in the cellular level. Sorry. So we come to the importance of endpoints. The endpoints is very important because shock is a spectrum which happens in the trauma care continuum. So it'll happen in the ED, it'll happen ongoing in your damage control resuscitation and in damage control surgery. And it just keeps on happening even with a great resuscitation on a patient who is exsanguinated significantly from a large artery, even in the ICU setting. So it initiates with the compensation, with a compensatory shock into an uncompensated shock. Despite normalization of numbers or physiology or parameters that you see on a monitor, there is going to be ongoing tissue hypoxia. And because of the irreversible damage to the end organs related to significant shock, it might take actually more time to actually clear the effects of shock to improve the oxygen delivery. So endpoints are very important to try and give you some guide for appropriate resuscitation. Also, it prevents us from over-resuscitating patients, because if you do give too much of fluid, too much of blood products, it does increase mortality. and vasoplegia associated with resuscitation. And also it causes significant injury to organs like the lung, which causes acute lung injury related to over-resuscitation. So Ajay has talked about this, and Russell has talked about this. There is the triad that you talk about of coagulopathy versus hypothermia with acidosis. It's a death triad. Everybody knows about it, and the significant over-resuscitation or under-resuscitation can worsen any of this. So what is the aim of resuscitation endpoints? The goals of resuscitation are to normalize the physiology through the restoration of the delivery of oxygen, and then also to try and optimize the HB to deliver the oxygen at the end point. And there are numerous methods to guide your resuscitation efforts in the treatment of shock, and they're all collectively known as resuscitation endpoints. So when is the resuscitation completed? After the initial damage control resuscitation and the damage control surgery. And once your resuscitation completed, there is a certain phase and a certain period. Sometimes it takes up to 48 hours for the oxygen debt to be repaid. So even if there is normalization of the number, unless your oxygen debt is repaid, you're still in shock. So tissue acidosis has to be eliminated. Again, it takes a period of time. And then the entire process of aerobic metabolism has to be restored. Sometimes you can see, in spite of your best efforts, the correct amount of ratio or of blood products that you've given, the damage control surgery that you have effectively done, sometimes in certain patients where the mitochondria doesn't have the reserve, you get mitochondrial failure, and then the failure then is effectively compromising the aerobic metabolism. So in spite of your greatest efforts, greatest resuscitation, sometimes these patients never recover because the aerobic metabolism in the body has never been restored back again. So what are the endpoints? There are three groups that you can talk about. One is the hemodynamic endpoint, there is the metabolic endpoint, and the regional perfusion related endpoints. In the hemodynamic endpoint, you talk about oxygen delivery equations and oxygen consumption. The Fick equation is the classic one that you use. You never use it on a regular basis as a clinician, but you have a rough idea what it means. So what are the specific endpoints that you look for? It is usually the mean arterial pressure. We try and put an arterial line as early as possible in these patients who are shocked. Our aim is to try and put it within 5 minutes. So we have got plumbing gurus hanging around just to try and get this as early as possible to guide our treatment, because this is one of the main things that we do to try and guide our treatment. I have mentioned CVP, pulmonary artery catheters, mixed and central venous oxygen saturation. These are all being published as endpoints, but I can guarantee you in the last 10 years, and there's a whole lot of evidence available on this, on cohort studies based out of Europe, US, and in Australasia, which says that CVP and pulmonary pressures are just not going to guide your treatment. It's completely moved away. We hardly look at CVP for guiding our hemostatic resuscitation. Pulmonary catheters are literally not used unless sometimes, occasionally, we have massive PEs. In that setting, we do use the pulmonary artery catheters. Mixed and central venous oxygen saturation has been debunked within the trauma resuscitation field and also within septic scenarios at the moment. So all these three are hardly used, but it is mentioned in the literature. But the bedside echocardiography or the bedside ultrasound has been a miraculous intervention in guiding your treatment. So the IVC caliber or the right ventricle, which sort of guides us on volume status and with differences in with respiratory variation. We use this regularly in ED, up in the theater, and also up in ICU to guide our hemostatic resuscitation. And it is a definite investigation for ascertaining endpoints for us to know the efficacy of our resuscitation. So putting it all together based on the hemodynamic endpoints, what are the sort of systolic blood pressure or that you can aim for? In a hemorrhaging non-TBI patient, there is significant evidence whether you have penetrating or blunt trauma, which is the predominant group that we see compared to the US. The systolic blood pressure, we aim for 80 to 90, great efficacy within the group of hypotensive resuscitation within blunt trauma also. Obviously, it has shown to be very efficacious in penetrating injury. In TBI, obviously, we need to maintain cerebral perfusion pressure, so we aim for a higher systolic blood pressure. But there's no guidelines and on a recommendation for a patient with hemorrhage and TBI, and it's going to be the clinician is going to decide on keeping a higher perfusion pressure, but making sure that the patient doesn't actually bleed further with us driving the systolic blood pressure to a higher level. So it is clinician based, and this is just sort of summarizing what sort of endpoints that you're looking for resuscitation. The bedside echocardiogram, as I said, is for us revolutionized care. There are at least 3 papers that we have published from Australia on this in the last 2 years on bedside echocardiograms using just an ultrasound machine, not a specialized echocardiogram machine. And you can see the right ventricular collapse, you can see the IVC collapse, and we use this significantly. Now I come to the metabolic endpoints. Obviously, as I talked to you about, there is an increase in pyruvate which converts to lactic acid, and that completely reverses, and there's anaerobic metabolism that is happening. So there's significant collection of lactate in the system. Now, so what are the specific metabolic endpoints that we can talk about? The first is lactate. So anything more than 3.4 if it is more than 6 hours of lactate more than 3.4, your mortality increases by 50%. And these are at least 6 or 7 studies in the last 10 years that have shown this, a consistent message on that. What more important for us is to try and see the efficacy of your resuscitation is your lactate clearance. If it doesn't clear within to less than 2 within the last 48 hours, your mortality increases to above 60%. So we look at it, lactate and lactate clearance very, very closely. The other component that we have seen is obviously it is related to the hypoperfusion itself. But what we are also seeing is lactate sometimes is a good indicator, not alone for gut ischemia related to hypoperfusion and general end organ damage or tissue hypoperfusion. We also see in a lot of blunt trauma patients where it sort of guides us to search for compartment syndromes actually associated with a CK rise. So sometimes with your resuscitation and the lactate is not clearing up, you really have to go and seek and search for areas of compartment syndromes. And one of the commonest places that is being missed is the gluteal region related to Morella-Valley lesions and deeper tissue destruction. And then there is a compartment syndrome associated. We've had in the last year at least around 6 patients where the lactate was not clearing out, and we had to go seek and treat this actually. The other metabolic endpoint is the arterial base deficit, and it is an indicator of how much transfusion these patients will require and what their overall mortality is going to be. pH always has been an endpoint, but is not a very specific endpoint. End-tidal CO2 is more and more people are looking at end-tidal CO2 to see what is happening related to the carbon dioxide and oxygen delivery systems. Survivors with hemorrhagic shock obviously had a higher EtCO2. Then the lower arterial EtCO2 differences was associated with better survivals also. Now, I'll quickly touch about the new metabolic markers, specifically ADAMS 13 and the soluble P-selectin. There are a few papers out there on this. It is very expensive. All of them are very expensive to actually keep monitoring, but there is some promise being shown in these two, the ADAMS 13 and also the SP-selectin. It is being, it's going to be tested in a large scale in France. They've already registered the clinical trial on this, and hopefully we'll have some answers in the next 2 years. About regional perfusion endpoints, that's the next endpoint that I would talk about. These are, I have mentioned the names, gastric tonometry, you're talking about gastric pH, sublingual capnography, and near-infrared spectroscopy. The NIRS, or the near-infrared spectroscopy, look for StO2, or tissue oxygenation in the muscles itself, and looks at oxyhemoglobin levels. Now, these are hard ones to do. Not many centers are doing this, and the multiple papers that have been published in systematic reviews have not shown any efficacy over the current standard resuscitation endpoints that we used. I think gastric tonometry is a difficult thing to actually do. So I don't think there's any specific value in actually following it. And we in the Alfred and most of Australia don't follow any of these regional perfusion endpoints. So finally, when you talk about endpoints, hemostatic resuscitation and hemorrhage control is a fourth endpoint. It is an endpoint because, as Russell talked and Ajay talked, if you don't control the bleeding, it is an endpoint. The damage control, bleeding control is an endpoint. So there has to be stretch on damage control resuscitation, damage control surgery. And I haven't written here, but we are significantly doing what we call as damage control interventional radiology. In the last year, in our shocked patients, which roughly comes to around 600 patients, we have only, in 3.2% of the times only, we have taken them into doing a damage control laparotomy. But in roughly 20 to 30% of these patients, we have taken them for interventional radiology. A whole lot of laparotomies have been replaced by interventional radiology. Things like lumbar artery bleeds, which we never used to be able to control before, maybe 10 or 15 years back, which had a 50% mortality rate. We are doing that through interventional radiology very effectively within the first hour. So that is a new field that has come in, and people who are lucky to have hybrid theaters where you can do both at the same time have got a much better outcome related to that. The other is obviously looking at the endpoints of coagulation profile, specifically INR and fibrinogen, and then talking about TEG or ROTEM, which Ajay already alluded to. And then there's the concept of thermal control. So as you read from the death triad, hypothermia is associated with significant causes, coagulopathy, increased mortality rate, and also increased acidosis rate. So that is in the severe hypothermic patients, which is less than 35. And but there is a mildly hypothermic patients where some data has shown that there might be some benefits to mortality. So that's the group of 35.5 to 37, and then the normothermic patients. So it is important to try and maintain mild hypothermia to normal normothermia to do a good resuscitation. So specifically talk about damage control, it is originally described with the Pearl Harbor attack. USS Nevada was attacked. It was the 1943 in US Navy was attacked. The simple philosophy was driven by the admiral in the ship, basically saying, save the ship and fix the pipe. And then it was obviously applied, that single and simple philosophy was applied to damage control surgery in 1976. In hemostatic techniques for the liver. Now, what is damage control resuscitation? I'm sure all of you know this, but it is immediate hemorrhage control, operative or angiographic, restoring blood volume, early initiation of blood products, and reduced crystalloid administration, and maintaining permissive hypertension. I can say within the Alfred and most of the centers across the world, we hardly are using any more crystalloids. Literally, we don't use crystalloids at all, with great effect to resuscitation. And we are definitely running, even on blunt trauma, and at a much lower endpoint for systolic blood pressure or mean arterial pressure to do resuscitation. And we are much more efficient to get them into theater, or now predominantly to angiography. So, the main aim is obviously rapid hemorrhage control, contamination control, minimizing the time where you are there so that the insult to the tissue and the ongoing resuscitation is minimized, so that you are improving, you are giving the ability for the body to recover from the insult that it has suffered over the last few hours. So to try and achieve early aerobic metabolism return, normalization of physiology as possible, as early as possible, you need to give rest to the body to recover, and then you can go in for definitive surgery. Now, Ajay already talked about the endpoint of getting the balance right. The proper trial showed that within 24 hours, if you do it in 1:1:1 ratio, there's a possibility of achieving hemostasis, but it didn't show any difference in mortality. TEG and ROTEM, it's already been alluded to, and the viscoelastic monitoring in trauma resuscitation is an endpoint. People use it as a guide to the efficacy of your resuscitation, as very effectively Ajay demonstrated with that splenic case. Now, the only problem is there's not enough evidence to guide this at the moment. The systematic review back in 2014 showed no difference in mortality in this group or transfusion guidance. There was a pragmatic randomized clinical trial comparing CCT versus, that's the second study that I'm showing, versus TEG in 2016 in Annals of Surgery, which showed benefit. But the problem with that study was the CCT return test took more than usual for an average level 1 trauma center. So it was not a well-conducted trial for that particular reason. So I don't think the inferences of that study can be taken. This in 2020 was published from the Gold Coast Hospital in Australia. It didn't show any difference using viscoelastic resuscitation as an endpoint to guide resuscitation. Didn't show any difference in mortality. Didn't show any difference in PAC cells. It showed a increased use of FFP and increased use of fibrin products as replacement, and it showed a decrease in FFP. At the moment, the evidence suggests that there's no difference in mortality, but might be differences in blood products. At this moment, there are 11 clinical trials on this happening, and the biggest one that is happening is in the UK. I think it's the Fiona Leckie group that is doing it. I'm very closely monitoring it because I think they will be powered to answer this question. At the Alfred, we did use the TEG for some time, but it is not being used significantly because we don't see any particular benefits at the moment when we did an audit to continue treatment with TEG and TEG to guide our endpoint resuscitation. Finally, future management, where are things going? Specifically, I am focusing on nanotechnology. I've got a grant from CSIRO, which is our scientific organization here in the Monash Institute of Medical Engineering. We are specifically looking at nanotechnology to do invasive monitoring, remote monitoring, in a concept like what we call as nanobots to guide you with multiple parameters in a tissue level, in a vascular level to guide us. So this is a process that I'm doing using the grant to do assessment and also to guide hemorrhage control itself. So it's an assessment module that I'm creating with the nanotechnology at the moment. We have created the nanoparticle, but also I'm looking at actually activating the coagulation cascade at the bleeding ends using nanotechnology. We have generally been successful in the early stages at the moment. Now it's in the animal models. Hopefully we will be successful in achieving both to achieve a particular particle within the body to look at endpoints of resuscitation or efficacy of resuscitation, and also to activate those same nanobots to try and actually do hemorrhage control occlusion of the large vessels. So how do you identify this patient at risk in ED so that when you see such a pattern, you know that you have to look at resuscitation endpoints to look at the efficacy of resuscitation. All data shows these are the parameters or these are the variables that you should look for. If they have a high ISS, their shock index is more than 9.9, their systolic blood pressure is less than 90, or if their base deficit is more than or equal to 6, if they're hypothermic less than 35, and if their INR is more than 1.5, and an elevated lactate in more than 3.4. So these are the ways to identify that these are the endpoints that are going to be guiding you the efficacy of your resuscitation. In summary, you've got hemodynamic, metabolic, regional, and hemostatic and hemorrhagic resuscitation endpoints. And I would specifically focus dynamic ones, the metabolic one, and the hemostatic ones. The regional ones is not really effective. In conclusion, hemostatic resuscitation is essential in shock from traumatic hemorrhage. This massive use of resuscitative crystalloids is really discouraged. Within the Alfred and within Australia, we hardly use crystalloids for resuscitation anymore. Even our paramedics are actively discouraged from using it. Adequate resuscitation is no longer judged by the presence of normal vital signs because it just doesn't give you the cellular level of hypoperfusion that is happening. Normalcy of organ and tissue specific measured values have to be achieved. Try your best. The search for a single endpoint at the moment is unrealistic, and you have to resuscitate with appropriate fluid. The quest is at the moment for a single endpoint for resuscitation in traumatic hemorrhagic shock. It is at the moment not available, but multiple groups, including I do know that NASA is also looking at this, and the US military is also looking at it. I spend my time in Shock Trauma Center. They're also specifically looking at this at the moment. So hopefully in the next 10 years, we will have a single endpoint for resuscitation to guide us in the efficacy of resuscitation. Thank you very much.
Thank you, Dr. Joseph. That was really a fascinating and interesting talk. And next year at ISTAC, I hope we can have more information about the nanotechnology, and maybe we'll have a beginning of the single endpoint to resuscitation. Thank you. We will start our question answer session. First, Dr. Winston can start off with a question regarding the current topic.
Yeah. Nothing much to add because Dr. Mayur was giving an overall picture, but I just wanted to ask Dr. Mayur, you mentioned about the role of the surgeon in intensive care, acute care, and being able to do an echo and everything. What is your take? Do you think in India we should train surgeons to look after intensive care units like you mentioned?
I do. I feel pretty strongly about that. I think that the care of the critically injured patient, again, if the concept is we are caretakers of these patients when they first hit our trauma bays in the emergency room, and then you are caretakers of them in the operating room, it's a continuum to do the same in the ICU. And so it's just a natural progression of where I think the care of the injured should go. And I think surgeons are best equipped to do that. No disrespect to my anesthesia and my medicine colleagues. So I am an ardent believer in that. I would love to hear, Joseph, Russell, and Ajay's points on this. I think that it is high time for it to happen. And you have momentum. I see Amit smiling there. I know that they feel strongly, they agree with me. The question is, how do you build momentum in this regard? You've done it with the Masters of Surgery program, the trauma, what's it called, learning curriculum. Why not do it for this?
Yeah, a good point to ponder.
Yes,
Any other questions?
Yeah, I think we strongly at our center believe that, and that's why our MCH is known as Trauma Surgery and Critical Care, and nearly half the time they are with us in the trauma surgery unit. They, out of the 3 years, they're posted in the trauma ICU, looking after the patients. Along, obviously, we have critical care specialists also. No disrespect to any specialty, but surgeons understand trauma and surgical aspects much better, and therefore the interventions we feel, if they need to be done, whether it is source control, whether it is anything else, are much better done by or much earlier captured by a surgeon who has already operated on that particular case, rather than somebody who is oblivious about the surgical nitty-gritties of the case.
Yeah, I've got a question for Dr. Ajay, sir. I enjoyed your talk, sir. I just have a small question. Do you think, I'm in the military, so I have got my reservations for fluid management in the combat zone. Do you think, sir, fresh, warm, whole blood can be a substitute for 1:1:1 PR-BCFFP platelet resuscitation? And the second question is, sir, we use a lot of dried plasma in case, because we can't store fresh frozen plasma in the field areas. Is dry freed plasma, in your opinion, as good as fresh frozen plasma?
Both are excellent questions. And in the US, there is a big move towards at least starting resuscitation with whole blood. But again, I always look at things a little skeptically, because you are correct. The whole concept of fresh, warm blood came from the Iraqi war, where they had walking blood donors. And these are young, healthy people, and it's very fresh blood. Will the same results be applicable in the civilian world where we have stored whole blood? I don't know. But yes, we are moving towards fresh whole blood, or at least limited lifespan blood. To your second question, a lot of study has been done by Marty Schreiber here, looking at freeze-dried plasma and comparing it to regular plasma. And most of his studies shows that it's equivalent and as good. So using freeze-dried plasma has a lot of advantages, as you rightly pointed out in the theater.
Thank you. Thank you, Vin.